Welcome. My name is Mary Miles, and I'm here today. We're going to talk about evidence-based medicine and what that evidence is showing us for why we should be using standing products. I'm hoping by the end of this course, you guys will have a better understanding of what kind of evidence is out there to support standing, kind of what the benefits are of standing, and how you can use some of that evidence. I personally use a lot of the evidence to help me when I'm writing letters of medical necessity. And you throw a couple research articles in there and write a good letter, and you typically get it approved. So whether you're a therapist or you're a supplier, I think to have some background knowledge on evidence can be something that can help you when you run into some of those obstacles with getting some equipment approved. So we're going to kind of move on and look at, specifically today we're going to really talk about pediatrics and why is standing so important for our kids. And I share this picture with you. I've done some work going down to Nicaragua and helping some kids down there. And they really don't have any equipment down there, and they don't really have a lot of intervention down there. So you can see from this little girl that she's got some things going on with her feet, and she's got some tightness going on with her hands. So you've got a PT and OT here. And we kind of laugh at this story because the PT said to the OT, "What are you going to do about those hands? She doesn't have any range of motion." And then you can see the foot is turned completely in. The OT said to the PT, "Well, what are you going to do about those feet?" So, you know, we'd like to think that if we had some standing going on down in Nicaragua, that these kids would be looking better. But let's look at what we can do here in the United States and abroad, and what we can do to help these kids start standing programs and prevent deformities like this from happening. So starting with, when should we start a standing program? When we look at kids in typical development, they're starting to pull themselves up to stand around 9 to 12 months. Their hips are ready for that weight bearing, and so for our kids, even if they're functioning at about a 3-month level or lower, we can start standing and doing weight bearing at the same time because the hips are ready. So we can get those standing programs going right at that 12-month time level with these kids with disabilities. We're going to talk a little bit today about different evidence that's out there supporting standing. And when I share evidence with you, just helpful to know that the researchers will categorize things from being level 1, which is a really high level of evidence, where they've really used some rigorous standardization, down to level 5, which tends to be more some expert opinion, and then you've got things in between that are a little less rigorous, and even some case studies and case reports that even though they're not as rigorous, I think it's good to have all these things to share and just help us, point us in the right direction. But outside of evidence, I think it's important as therapists to remember that what we're doing in practice and what we're seeing with our kids is a big piece of what we do and why we do standing with kids. So I kind of want to share a little guy that I see for therapy or saw in the past that just really illustrates why standing is so important. This little guy I got when he was about 13 months old, and I think the big thing to know with him is he had really low muscle tone, and he was one of those floppy kids that you could kind of try to do some bouncing, and you just could not get him to weight bear through his legs. He was very floppy in his trunk, very floppy in his arms, so really could not get any weight bearing in any of those joints. I work for a school district with some kids in birth to 3, and I think we tend to use this Help Hawaii Early Learning Inventory profile that helps give us kind of a checklist of what kids are functioning. And so when I got this little guy, he was functioning at about a 3-month level. But I didn't hesitate. He had really good hip integrity, and he was around 13 months old. So we decided to get him up and standing. So you can see this cute little picture of Peyton. We struggled a little bit to find a standard that fit him, but we got everything adjusted to the smallest it would go. And I don't know if you can see in this picture, but we did have to use knee immobilizers to help support him in standing. And this picture took us quite a while to take because he does not have a lot of head and trunk control at this stage. His dad got out the iPad, and we finally got him to get his head up because he really couldn't even support himself with his arms when he was first standing in the stander. So it was kind of a little bit of a trick to get him to be able to even stand for 10 to 15 minutes when we first started. So it took us a while to get this picture, but he's cute as can be. And what was interesting is 6 weeks into using the stander, he started at about 15 minutes a day, and his parents both worked full time, so they typically could not get more than 15 minutes a day, except on the weekends. They could do a couple of times a day. But within 6 weeks of having him in the stander, he was starting to do some weight bearing, and they could prop him up against the couch, and he would lean on the couch if they were holding him and get some weight bearing through those legs. And I think in 6 weeks of standing, it's not the therapy that I did that got him going. It was definitely getting him up in the stander, and he had to use head and trunk and legs, and he finally developed enough stability with that repetition and that repeated loading to get some function going. You can see him down the line here, the picture on the left. He's probably about another year down the line. He's sitting independently, playing with toys. He was kind of getting in and out of sitting. And then by the time he was around 31 months, 32 months, he was doing some independent walking. So pretty exciting for this family that their little boy went from not being able to do really very much to walking by the time he turned 3 and going into preschool, getting more special ed services, but being able to walk by himself. So even though we have a lot of research out there, I think as therapists we have many, many more stories about why we need to use standards, and we need to share those stories and then maybe back up some of that with research when we need to help parents understand why it's so important. So let's start today talking a little bit about what is the research showing with bone density and what are we seeing there. And I like to start and just talk about, if you think of Wolff's Law, which is just saying that bone in a healthy person is going to respond to all the loads that are placed on it. So the more we're loading our bone as normal individuals, you can see that we have a healthier, denser bone. And I think if we really think about that with our kids, their opportunities to load their bones and develop that bone density, we're going to have to try to be creative with getting more opportunities to load their bones and improve that bone density. And we'll talk a little bit more later how even just loading those bones, kids are loading them in abnormal positions, and so we've got to really be good as therapists in helping them get up and standing and loading those bones in some normal lower extremity alignment. Before we look at some of the research, I want to just talk about when bone is formed in kids. It's interesting to note that a large majority of our bone for kids is developing in those pre-puberty area and kind of right into puberty. So if you can see from these stats that 35% of their spine bone and 20% of their long bones are really gaining a lot of bone density during those puberty years. And so we need to make sure that we're doing a lot of loading and a lot of standing for these kids during those years leading up to puberty and through those puberty years. So we've got to be thinking, as we're working with these kids and they're growing, that we've got to keep them healthy so that they can continue to stand through those really important puberty years. And it's interesting to look at some of the studies that are out there that support pediatrics. Not as many studies in pediatrics, and we'll look a little bit at some adult ones that we can use too, but if we look at the 6 pediatric studies that are out there, a couple of them are really high standard levels of evidence, and they really showed that you're seeing a lot of vertebral bone mass density, but not as much in those long bones. And as we look down further in the talk today, kids are really susceptible to fractures in their long bones, so we've got to really make sure we're standing enough to get some bone density going in those long bones as well. When I look at that study, I think some of the issues with some of those studies is that they didn't have enough time in their standing. A lot of the studies were looking at having kids stand for 10 minutes a day and maybe 3 times a week. And we'll talk a little bit more as we go on how much should kids be standing and what should the frequency be. And I wanted to share this one adult study because I think it gives us a nice baseline that we can kind of translate and use with our kids. It's a study that looked at adults who were injured with spinal cord injuries, and they took and did a study watching these individuals for 2 years, and they wanted to see if they had them do standing for at least an hour a day, would they be able to maintain some of that bone mass density. And so here we're looking at normal bones, and we just want to see, can we maintain that bone mass density? And this study really shows clearly, if you look at the graphs, that even after 1 year they were maintaining it, and then 2 years later they were still maintaining that bone mass density. And I think that's kind of important. We don't have as many studies for pediatrics, but I think we can use what we have for adults and kind of infer that we would be able to see the same thing with our pediatric population. Okay, so following that adult study is a pediatric study that I think is really interesting. It was not included in that previous slide that I talked about that looked at the 6 pediatric studies. This one never got fully published, so it's really only published in an abstract version. But I think even if we look at that abstract and what it showed, they had the kids with non-ambulatory CP stand for 2 hours a day, and they followed them for 9 months. And what they found is, even though there wasn't perfect compliance, 2 hours a day is a lot of time to stand. These kids who were standing at least 7.5 hours a week, so an hour a day, were getting increases in bone mass density in those weight-bearing bones. And so I think that's a nice study that kind of goes along with the spinal cord injury study. And we're showing again, we need an hour a day to show some increase in bone mass density. And kind of followed with that, there was another group that did a study, and they looked at physical activity and bone mass density. And I think this is a nice study because it shows just doing some physical activity is going to increase bone mass density. And they did a nice study where they had kids who were kind of matched for their age and if they could walk and what their walking level was. And they had half of the group was a control group, and the other half got 60 minutes of PT 2 to 3 times a week. And they made sure that their PT protocol was 20 minutes of upper extremity exercise, 20 minutes of lower extremity, and then 20 minutes of trunk exercise. So they're all following that same protocol. And you can see that on the graph here that these kids who had that physical activity showed some bone mass density increases. So this is great, and how do we translate this into our practice? I think for me, what I try to do is we've got standing going with kids, and if we can really talk about other ways that we can get kids active, maybe get kids adaptive bikes at home and some other things that they can do so that we're getting a little bit of physical activity going with these kids and knowing that it's making a difference not only in that exercise and strengthening, but it's also improving that bone mass density. I'm going to talk a little bit about dynamic and passive standers. Dynamic stander is kind of a new thing that's out where they're talking about kids being able to shift their weight and move while they're in a stander. And so there's been some studies done looking to see what is the difference between those two kinds of standers. And definitely they're showing that the kids who are using some dynamic standers, whether it be with some whole body vibration or just doing, this one you can see she's doing some movement by moving her arms and then getting a little weight shift while she's using the wheels to move the stander forward. It's making a difference in improving that bone mass density. And I think in practice, you're not seeing a lot of dynamic standards out there on the market, but I think we can as therapists do some things with our standards that we have to help kids be a little bit more active in them. If we look at when they're in a stander, maybe they're doing some upper extremity activities and fine motor activities, or maybe they have to reach a little bit more so they get some natural weight shifting. Maybe on some of the smaller standers, we can get them on a rocker board and do some rocking and moving on the stander. And I think for me, one of the biggest ways that I try to incorporate a little bit more dynamic standing is I have some of my older students who are using some sit-to-stand type standers, and sometimes they'll take a break in the classroom and then they'll get back up and stand. So we're effectively getting some repeated loading, which is kind of simulating the same thing as a dynamic stander. Another study that they did on dynamic standing, again, showed that dynamic standing is going to improve that bone mass density. I thought this one was interesting to throw in because they looked at what was the behavior in these kids, looking at their alertness and could they pay attention more if they were in these dynamic standers, and there really was no difference between the dynamic stander and that static stander type of group. So I thought that was kind of interesting because I thought maybe get that whole body vibration under their stander or do some movement in the stander, they'd be more alert, but they really didn't see that when they did these trials. So kind of going back to what I was saying about repeated bone loading, again, I was talking about in practice, a lot of times my older students will be using a sit to stand type stander. And there might be times during their day that they need to sit down and be with the group at the table, yet they're going to get back up and stand to be doing something up at the smartboard with the group. So it's easy for them to stay in that stander and do some work and then later get back up into standing. So they're getting a lot of repeated bone loading, which is really going to help with that bone modeling and density. And I think it's nice that we have a study, this was done by Stuberg, that really showed that repeated bone loading is going to improve that bone density. And again, he looked at how much time do we need to be up in the stander, and he again came up with 60 minutes, 4 to 5 times a week. So, you know, now we have another study that really says 60 minutes a day is kind of the amount of time we need for bone density. So even though we don't have perfect studies, we've got, I think, enough that shows us that this should kind of be our standard guideline for what we're telling parents for standing. And then I want to talk a little bit more about joint integrity. We know these kids that we see with cerebral palsy are going to have a higher incidence of some hip problems. A lot of times they're going to start out with having pretty normal hips, but we have kids who have abnormal muscle tone, and if we think back to Wolff's Law that the bone's going to grow and move and change in the direction that it's pulled and the forces that are placed on it, and these kids are going to have abnormal tone that's going to pull their hips in the wrong direction. So it really makes things so much more important that we get these kids standing up in a position that's going to pull their bones in the right direction. So we've got to really look at getting them standing with their bones aligned under their hips. There's been a little bit of a movement in trying to get kids standing with a little more hip abduction. So for the therapists in the crowd who understand that, you realize that you have your hip socket, you have your hip bone, and when you're standing in neutral alignment, that bone is really firm into that hip. You've got kids who have tone and they want to pull their bone in, and then their hip starts to come out. So if we can get them in what's called hip abduction or outward, we're rotating that bone that way, and you can just see that that bone is going deeper into the socket. So I really like that when we're thinking about getting kids up and standing. If you can even get a little bit of hip abduction and separate that out and feel like you're keeping their knees safe, that's a nice way to start trying to get a little bit more hip integrity and prevent some of those problems down the line. Study that was done in Sweden looked a little bit more at hip integrity. And this was a pretty large study that was done over a 5-year period, and I like it because a huge amount of kids were involved. 206 children were followed. And the study did involve having these kids come in who they felt were going to be more susceptible to hip problems. So they were talking and looking at those kids who were going to be wheelchair users. So they took this group and they did some muscle tenotomies on them, but then they had a huge follow-up program where they were doing some positioning and doing some standing, and they had a protocol that they followed. And unbelievably, none of these kids had a hip dislocation in the time that they had this protocol in place. And so we don't have this going on here where I'm working, but I think if we look at what can we do as therapists to implement some of what they tried, really doing some good positioning, looking at when they're standing, getting some of that hip abduction if we can, and doing the positioning with hip abduction to try to prevent some of those long-term problems. And I think really starting early, we can get these kids up and standing at 9 to 12 months if we can have them identified early enough. And then hopefully we can prevent some of the problems in the hip dislocation that can naturally occur with some of these kids. We'll follow that with a little bit of looking at fractures and how can we prevent fractures. We know that with these kids with cerebral palsy that fracturing some of those long bones in the legs seems to be the area that they're fractured the most with. I like this study that looked at following the risk factors for kids with cerebral palsy. They looked at 500 kids and they separated them based on their functioning level. So the higher level kids who are functioning, as therapists, we classify kids under something called the gross motor function classification system. So the higher functioning kids would fall into those levels 1 to 3. And then those lower functioning kids would fall into what we would call gross motor functional classification system level 4 and 5. So they're more involved, they're using wheelchairs all day long, they're probably not kids that are getting out and doing any sort of ambulation. Maybe doing some transfers, but really relying on those wheelchairs for getting around. Interesting to see that the kids that were higher functioning really didn't show increased risk of fracture that was any different than your typical child developing. But not surprisingly, these kids who are lower functioning in that level 4 and 5, they really showed a big incidence of risk of fracture. And I thought what was interesting is the correlation with malnutrition and G-tube feeding and then being on anti-seizure meds. And I'm sure we all can think of many, many kids in our caseload who have those things in place. And if you think about being on seizure meds, a lot of times you're not absorbing the calcium like you should, and so you're not really getting the nourishment that you need to your bones. So if we think as therapists, what can we do to help these kids? It's not our place to recommend supplements, but if we can maybe get them going to the right doctor who can get them some supplements and make sure we're getting adequate nutrition really early on, we can help prevent some of those fractures. But I think more importantly, the big thing we can do is really get these kids doing some regular loading on their bones. Identify them early, get them doing some standing early, and now we know we need to do at least an hour a day. So if we can try to get kids standing an hour a day and really, hit home to parents how important this is and the fact that they could be preventing a lot of future problems if they're doing it. Now we'll move on to talking about range of motion and how we can use standing and how standing helps with that. And for me, this is an exciting part as a therapist because we fight so hard to maintain the range of motion of the kids as they're growing. And it's nice to see some studies that are really showing and verifying that standing is helping with maintaining that range of motion. I think it's interesting, you can see the study showed that getting kids up and standing is going to maintain the knee extension range of motion and prevent those contractures. And then it's showing that if we actually stop standing, that range of motion is going to decrease. And I think as a school therapist, I can definitely vouch for this. There's kids who maybe even aren't doing as much standing during the summer, or if they're doing standing at all, and they come back in the fall, and boy, it's really hard to get what they were able to do back again. I'll talk about a little girl in a few minutes who missed a lot of school and during that time wasn't able to stand from some medical complications, and she really lost the ability to do standing pivot transfers, which I think is a huge deal because if you can't do a standing pivot transfer with one person, then your care automatically moves up to you have to have 2 caregivers to lift and transfer you out of your wheelchair. So we worked very long and hard, and we're finally regaining that ability with her. And it's been just through a tremendous amount of positioning and standing and just trying to get her back to where she was. So again, this study showed that you really have to stand for a minimum of 45 to 60 minutes a day if you want to get that optimal improving of hip and the knee and ankle range of motion. So I think it really ties nicely with what we would be doing for bone density. The study also showed that if you look at doing range of motion, so our typical range of motion where we're doing maybe a 30-second stretch, that sustained stretching where we're getting them standing, full knee extension, full dorsiflexion, or at least 90-degree dorsiflexion, hip flexion is hopefully in neutral, that we're getting a longer sustained stretch, and it's a much better way to improve range of motion. I'm going to talk a little bit about Zach, who's a perfect example of this. He was a 5th grader when he came to the district I work at, and he had some knee flexion and hip flexion contractures. He was doing some standing for transfers with one person, but it was really quite a task because when you don't have full hip and knee extension, it's really hard to maintain that standing position, and so he just could not sustain standing for long enough when he was doing some bathrooming, and it was very cumbersome for one person to really take care of him because he didn't have that endurance. So we got him up in a stander, and initially he was in some knee flexion and some hip flexion in the stander, and we had him in a sit-to-stand type stander that allowed us to get him up, let him kind of get used to it, and then after about 5 or 10 minutes we could go and pump the stander up a little higher and get a little more knee extension, a little more hip extension. And it was a process, but I would say over a 3 to 4 month period we really were able to get him to where we got him into full hip and knee extension in that stander. And so by really improving that range of motion, we were able to see much more independence with what he was able to do in the school day. So you can see here he was doing some nice transfers out of his chair. In the bathroom, it was just so much easier for staff to help him. He became where he could just hold on to the bar in the stander, pull himself up to stand, and somebody could help him with his clothing, and he could stand for quite a long time. So it was really exciting that we were able to improve that range of motion with him, and he's now a middle schooler, and the one thing we've had to do a little bit different with him is he's going through a growth spurt, so instead of having him stand once a day, which would kind of fit into our elementary period, he's standing twice a day at school, and he often will stay in the stander and maybe do some seated activities in the stander, and then he'll get back up to standing for some activities up at the smart board and some math things. So it allows him to do some multiple loading, which we now know is going to help with that bone density, and we're easily able to get an hour of standing in at school. So if he ends up having a really busy night at home, his family doesn't have to worry as much about adding that standing piece during the week time at home. Let's look a little bit about how standing can help us with reducing spasticity. There's some studies out there that show that definitely we will see some changes from doing that standing and weight bearing, and it will help decrease spasticity. 7 different studies were reviewed to look at the effects of that, and overall they were seeing decreases in spasticity, with some of the studies showing that those decreases in spasticity would last for about 35 minutes. So what do we do with that? We've got some decreased spasticity. How do we use that as therapists? Because if it's only lasting for 35 minutes, is it really benefiting these kids long term? I think what I like to do with that information is maybe get these kids up in standers prior to when they're going to go do something functionally afterwards. I have some kids who maybe are working on moving from being up in their stander and being in their wheelchair to try to do some walking in the building. And so if they're going to do some walking, I might have them in the stander prior to when they're going to do some walking. And that kind of helps them just be able to relax that tone and do a little bit better with their walking and be more successful. This young man in the stander here is a good example of somebody who has a significant amount of tone. And when he was in his middle school years, his parents, grandparents were taking care of him and decided that he shouldn't do any more standing because he was walking. He had learned to walk around the halls, and he pretty much parked his wheelchair when he got to school, and why did he need to get in a stander? And I tried to explain to them that, despite the fact that he's walking, he really was very, very tight in his legs, and he was in those middle school years where there's a lot of growth going on. And I was concerned that if we didn't do some extra things, we were going to progressively lose that ability to walk, because he was pretty slow. So he did stop using the stander, and as he grew more, he got a little bit tighter, and then his stride length and his walking speed started to slow down. And then this is a picture of him in high school, change of heart from the grandparents, and he decided maybe it was okay if he started standing again. If you think about that school day, just our typical kids are doing so much time sitting in classes, and so I think it's okay if these kids who are walking and walkers, it's still appropriate to have them in standers and standing, because you're going to get that muscle stretching and you're decreasing that spasticity that's going to help them maintain that ability to walk throughout those high school years as well. Talking a little bit more, I'm going to move on to looking at motor skills and how does standing help with our motor skills. There's some articles out there that look at what can kids do with walking speed and what can they do with using their upper extremities if they're in standers. And just like I talked about with the young man who went through middle school and into high school and stopped doing standing, he kind of decreased with his range of motion and his walking speed. They showed in these articles that kids who are doing standing are going to have better walking speed after they're done standing, and stride length and stride time is going to be improved. So it supports what I'm seeing anecdotally with my kids. It's nice to see that the evidence out there supports what we see. I did think it was interesting that there was a study too that showed that fine motor skills can also improve from doing standing. They had done some testing with some kids up in a standard and had used some standardized tests with fine motor activities. And the kids who were doing the activities in a stander versus in a seated position, they tested the kids doing the same test, the same child doing it, and they were able to complete more activities on that fine motor standardized test than they were in a seated position. So kind of exciting for OTs that maybe we're getting them up and standing and they have better trunk control, maybe some of that tone is reduced a little bit, and then they're able to use their arms in a better position. And those studies were all done with kids in a standard that had a nice tray that was at the right level for their body. Talk a little bit about muscle mass and how standing can affect that. This was a study that was done, again, on some spinal cord injured patients, and looking at, we do have the denervation atrophy that's happening from the injury to the spinal cord, but then if we're not doing standing and reloading that body, we also are having some disuse atrophy. So I think it ties into that earlier study that I showed, where if you're doing some loading on the body, you're going to improve bone mass density. Well, if you're doing some loading on the body, you're going to be able to maintain that muscle mass as well. So that's exciting if we think about our kids who probably don't have normal muscle mass. We've got a lot of skinny kids with cerebral palsy. But if we're doing some repeated loading, we can really make some difference on their muscle mass. And I like to think back to even the study, or the case report that I did on Peyton and Zach, where you saw they both did standing, and then all of a sudden they were able to do some standing outside of the stander. And Zach did more standing and got up to full range of motion, and as he did more standing, he was able to do more functional standing for things like toileting and transfers. So it does make a difference. If we're doing standing, we're building some of that muscle mass too. And again, we talked earlier about getting these kids positioned in the developmentally appropriate position. So when we're looking at standing, that's a huge piece of it too, making sure we've got kids aligned in the right position. And just knowing that a lot of our kids with cerebral palsy need that repetitive standing to get the motor learning along with the strength building. So oftentimes we're getting the strength, but we're also getting them understanding that, oh, I'm standing, I can do it outside of a stander. So they just need that repetition for that motor learning as well. And then I kind of want to summarize the end of the talk looking a little bit at how does standing affect kids' self-esteem and socialization. It's a big factor for these kids. They can get up in these standards, and then it's oftentimes the first time they're at the same level as their peers. I think it's interesting to look at what the studies are showing for social interaction, and definitely across the board, if you look at studies that interview different PTs or interview parents, everybody seems to agree that socialization can be a big piece of it. I think it's also interesting when you interview some of the parents, they're finding better results with those parents who are using the standards more often and find meaning to it, which makes us think we've got to help parents find a time that works for them and has meaning for them. We can give them standards, but if we don't really work at what's going to be the most meaningful time for them to use it, we're not going to see the carryover. And so greater satisfaction with social impact from parents if they were using the standard in areas that were meaningful to them. We'll kind of show the last slide that has a picture. I wanted to show how social some of our kids can be up in their standards. This is a little girl I talked about, Lily, who had lost some range of motion and regained it and regained the ability to do transfers again. We do a holodazzle parade at Christmas time at our building. And what's fun for me is we have the regular ed kids come down and help the kids decorate their equipment, and then we do a parade around the school. And a lot of the kids in the school have never seen some of these kids up in a stander. So they're finally, for the first time, maybe face to face with these kids, and they make comments like, I didn't know Lily was so tall, or wow, I didn't know she could stand up. I thought she only used a wheelchair. So it's really fun for those typically developing kids to see that interaction and see these kids standing, and the smiles on the kids' faces when we're doing this activity is unbelievable. It's priceless. So I had to just share this picture because it's exciting to get them up, and for these guys, this is the most meaningful time to use their stander because they're with their peers and they're doing something that is functional to them. So let's kind of close with that take-home message that we know a lot about why standing is important, but in the end, if we can't get the parents to buy into it and find a time that's meaningful for them and can fit into their life, then we're not really going to have those benefits. So we've got to really work as therapists to help families figure that out at home too. Thank you.